And now James Davis is going to ask a few questions to Professor Gordon Smith, who is joining us to talk about the issue of scans.
Yes, Professor Smith, thank you. I understand you have an interest in novel approaches to preventing adverse outcomes, and yes, the idea of a third scan in particular beyond the 20-week anatomy scan. I wondered if you could outline the findings of your research in that area, please.
Yeah, so there's a number of things that can be assessed in a late pregnancy scan, and one of the things we've really focused on is a scan near term. Term is the due date's around 40 weeks. We think about a scan at 36 weeks as trying to really stratify women for risk as they're making plans around location and type of birth. And so we evaluated over 4,000 women having first pregnancies, where we performed ultrasound scans and then followed the natural history of the pregnancy. And we've also combined that with some health economic analysis. I mean, to me, there's one kind of open goal at the moment, and that is the presentation of the baby. So midwives routinely at the moment perform palpation to determine whether the baby's head first or otherwise. But what we know from research is that anybody doing palpation detects about 50 to 70% of non-cephalic presentation, and they miss the remainder. And in those cases where the diagnosis isn't made, the woman then loses the opportunity to have interventions. So the baby we can attempt to turn the baby using external cephalic version, or they can have a sort of discussion around the plans for planned cesarean section or planned vaginal breech birth. It's one of these situations where you really want to know the information before you go into the situation. But what happens is quite large numbers of women go into labour with a non-head first presentation, and the diagnosis is made at some point during the labour, and those women will end up with often emergency cesarean section or taking the risks of an unplanned breech, which then can sometimes lead to death of the baby. So since we published our research, we were contacted by mothers who had had undiagnosed breaches, complications during labour with bad outcomes, and uniformly they were positive about the idea of doing a presentation scan, because it seems almost self-evident that it would be beneficial. The thing that we would caution is that there are lots of other things you can do when you do a scan. You can assess the size of the baby. Is it small? Is it large? You can look at the blood flow. And the clinical usefulness of these is a little bit less certain, because there's the potential for false positive results. We think the baby is small, we think the baby is large, and it leads to intervention which turns out to be unnecessary because the scan was a false positive. But in the case of presentation, it's a binary thing. Midwives currently try to palpate. The scan tells us for sure.
Yes, thank you very much. So you would say that in terms of breech presentation alone, that there is sufficient evidence to warrant that third scan at 36 weeks or so?
Yeah, so my assessment would be that there isn't a research question left other than what's the best way to implement this. I mean, would you have midwives, say, with handheld scanners? Would you have women attending hospital to be seen by a trained sonographer? To me, the outstanding research question is principally around how do you implement this.
Yes, and do you think it's practical in terms of the investment of manpower, essentially, the number of ultrasonographers that would be required, bearing in mind that there's been difficulty recruiting simply for what the current provision requires?
So when you're teaching junior doctors, any junior doctor in delivery unit would learn the basic skills to assess presentation out of hours as an emergency. And ultrasound assessment of presentation falls into that category of see one, do one, teach one. I mean, this does not require advanced levels of ultrasound skills, and it seems to me to be feasible. There are now point-of-care ultrasound devices, and staff could be trained to do this fairly simply. And the other thing you have to set against those costs of time in making the diagnosis versus the costs of time in failing to make the diagnosis. Making a diagnosis in labour in the middle of the night, staff being devoted to doing the caesarean section, resuscitating the baby, the whole delivery unit's emergency theatre being occupied for something that was potentially avoidable. You all out of hours work creates risk. And so that investment of time to make the diagnosis antenatally seems to me to be potentially very worthwhile.
So in other words, what you're suggesting is a basic ultrasound scan to look at the presentation of the baby, as opposed to one that's perhaps looking at fetal abnormalities as well.
Yeah, or particularly growth abnormalities at that stage in pregnancy. Now, I do think there's scope for a late pregnancy assessment of well-being to try and pick up risk factors for stillbirth. And so that's a major focus of our research, is what can we do at that point just prior to term to have better risk stratification. So I liaise very closely with SANS, the Stillbirth and Neonatal Death Charity. They had a survey of the bereaved patients, and 60% of their survey respondents have been told they were low risk, and they went on to have a stillborn baby. And that's a manifestation of the fact that we're not that good with our existing tools at identifying risk factors for things like stillbirth. But the danger is, in our attempt to try and do something about stillbirth, we create lots of unnecessary intervention without actually preventing stillbirth. So for me, the stillbirth prevention side of it is still very much in the developing new knowledge. The breech presentation, to me, it's a question of how do you implement it.
Okay, thank you. I wonder whether our representatives from the Royal Colleges have any views on the deliverability of what's been suggested.
I'm happy to come in here. Thank you. I think Gordon's suggestions are extremely good, and the point of care testing, scanning for presentation is certainly in play in several units around the country, and indeed very successfully. It's in play, in fact, in my own unit here in Norwich. And so that certainly has efficiencies. The assessment of the small or the extra large baby or potential risk factors for stillbirth, I think that does open up quite a hornet's nest trying to work out whether it is appropriate. And as Gordon says, I think a lot of effort needs to go into researching this area so that we can get the right answers to whether we can do it, because fundamentally that will need quite a significant investment in sonographer time. Now, the sonography is a specialist area of sonography for maternity and pregnancy, and so we feel that if we were to add in another scan, then that would put significant pressure on the system that we have now to look at in the details that scan would need to look at the risk for stillbirth, and also whether they're large or small babies. So overall, at the moment, I'm not sure the system could cope with that in terms of staff numbers. So it would need to be thought out very carefully. And therefore, I think probably research into it to get the most efficient way of learning from these scans would be the way to go, in my view.
Thank you very much. Gill, do you have anything to add?
Yes, I mean, I just build on what Eddie's just said. I mean, sonographers are a part of the workforce where there are huge shortages. I think it goes back to the women, women's choice as well, that if there is evidence that having a third scan is going to give them a better outcome if they have a breech birth, then actually the women should be part of the decision about whether to have that third scan or not. Women do have very clear views of whether they like scanning or they don't. So it will be, at the end of the day, all of these things plus the women's views, which is the bit we haven't mentioned. I mean, in terms of preventing stillbirths, I think we have opportunity to do that other than scanning. So Eddie, I was surprised Eddie didn't talk about Tommy's funded programme between the RCM and the RCOG, the Maternity Improvement Centre, who at the moment are doing a huge piece of work on placental function with an app. So I'll let, hopefully there'll be an opportunity to talk about that. But I think all of these things link together to help all of us work with women to risk assess or to look at their risk of poorer outcomes, and that we all need to work together in trying to do that well.
Thank you.
Professor Smith, would you feedback in response to that finally?
Yeah, so when we did our research study, we actually went back to talk to the women who, years after the birth, you're imagining they might sort of say to us, what study are you talking about? And we interviewed 20 women who had a breach identified by the research scan and then subsequently intervention. And what we had fed back from, so midwife went to the houses and interviewed them, was universally positive. And you're really quite moving in a way. Women saying, I sometimes wonder what would have happened if I hadn't recruited to your research study, because nobody told me my baby was breached until I turned up for that scan. So I absolutely 100% agree. Everything we do in maternity is driven by the women who are coming to us and looking for care. And our experience of the women that we diagnosed with breech presentation was uniformly positive.
Thank you.
Thank you very much.